Everybody, welcome to Cosi Talks Live. I have a very special guest with me tonight. We got Dr. David Doherty in the house. Thank you for being with us, Dr. Doherty.
Thank you for having me.
Guys, we're going to give you guys a couple of minutes to jump on board. It's a nice big show tonight, and I want to make sure that everybody who said they were going to be here gets a chance to jump on board. I'm also going to go ahead and start the Instagram live feed. So we are going to go ahead and get started there. As you guys jump on board, let me know who you are, where you're from, and what is in your mug this evening. I'm going to go ahead and get this Instagram live started. All right, guys, I see some of you jumping on board. All right, this is the part where you got to wait just a little bit. Let folks get on board here real quick. All right, let's get this Instagram going. All right, there we go. Ooh, all the comments started coming in. Are you seeing the comments there, Dr. Doherty?
No, they look
All right,
great.
we got Rich coming in from Arkansas with Kona. I hope that means Kona coffee because that's one of my favorites. We got Ginny on board. Ginny, thank you so much. You did an Instagram live feed and she was helping promote the show for tonight, so I really appreciate that. We got Susan on board. Susan's my girl right there. We got Kimberly and Rolo coming in from, it's Earl from California. We got Mary on board. She's my surfing pirate right there. We got Pam coming up from upstate New York saying hello. And Tom says, I still stuck at the rehab center getting some work done on my leg. Long day, Tom. I am happy to have you here, man. Happy to have you here. All right, guys, we're seeing a few of you guys jump on board. Sorry, guys, the Instagram is just being a wee bit cranky. So I am finally, ta-da, live on Instagram. There we go. Now we can get the party really started. All right, for those of you who are watching the replay, just throw replay into the comment section. And if you have any questions for Dr. Doherty regarding osseointegration, put them in the comments section. I'll be reviewing these comments after the show closes up and answering those questions as well. We got Emily coming in from Central PA. She always has the best drink, strawberry, watermelon, Crystal Light. We've got Robert coming in from West Plains. All right, it's a party. All right, guys, we are going to go ahead and get started because we have a big show with lots to talk about tonight. So let me do the official introduction. For those of you joining me for the first time, welcome. My name is Cosi Belloso. I'm a physical therapist, amputee specialist here in Tampa, Florida. And with me tonight, courtesy of Integrum, is Dr. David Doherty from Texas. And I'm going to let him tell a little bit about himself.
Hey, everybody. Real honor to be here tonight, and this is going to be exciting. I hope we get a lot of info out, but myself, I'm joining from Houston, Texas. I'm assistant professor of orthopedic surgery at the University of Texas, and my day-to-day job is a lot of hip and knee replacements. Those are awesome patients, but something near and dear to my heart, something that I've been pursuing for many years now, and really excited to make it part of my practice is osseointegration. And I can tell you that the rewarding aspects of that are they just really dwarf the hip and knee replacement population. We get to do a lot of really incredible work. We get to know the patients, and we get to work with a big team and make it a big multidisciplinary approach. So I'm excited to talk all about it and learn some things and hopefully give some knowledge out to everybody.
Thank you for being here because I know you're a busy guy, and your unique perspective on osseointegration is just going to make this show really wonderful. We've got Ed coming on board. He is a fantastic physical therapist over at Johns Hopkins. We got Kathy, says she got her permanent prosthetic leg. Congratulations, Kathy. That is a huge accomplishment right there. We got my other Pam coming in from Indiana. All right, so guys, tonight, unless you've been living under a rock and you haven't seen all the promotions I've been putting everywhere on social media, we're going to be talking about the different types of osseointegration. When I first encountered my very first osseointegration patient back in 2018, I had no idea what I was looking at. I had been called in by a local prosthetist to come and see a young man who was a bilateral above the knee amputee, and he had had the surgery done abroad out of the United States. And I first saw this surgery and I wasn't really sure what I was looking at. And that's what definitely inspired me to go out and start learning. And I found out about Integrum. They are the first and only FDA approved osseointegration device here in the United States. But I was soon to learn that there was more than one type of osseointegration. Not everything is created alike. And this is a show I've been wanting to do for a very, very long time. I see a lot of discussion on the Facebook support groups and on social media about the different types, which one's better, which one's superior, which one should you have done. And there's a lot of good information, and then there's also a lot of misinformation. So that is probably the mission of this show, is to provide you with credible and valid information on everything related to recovery from limb loss. So Dr. Doherty is very humble, so I'm going to brag about him just a little bit more. He is well-versed on both types of osseointegration, and we're going to be going into detail about what those different types are, okay? So guys, go ahead and feel free to put your comments and questions in the comments section. And before we get started, I promised we have some giveaways tonight. We have two $25 gift cards, guys, and I'm going to get fancy. I am going to post a QR code, and I'll be posting these codes throughout the show. So this first code, you might recognize that gentleman right there in the picture. This is to find a surgeon near you that has been trained in OPRA, specifically the OPRA implant system for osseointegration. So guys, if you want to just look around and find someone near you who may be able to answer your questions, scan the QR code and fill out that form. All right, so let's get started. For those of you who have never heard one of my talks on osseointegration, okay, it's basically in the word. What does osseointegration mean? When you take bone and you integrate it with metal. And in the human body, we use titanium or some sort of titanium alloy because it reacts really well and it fuses really well to the body. All right. So the first evidence of osseointegration we saw was in the 1960s with a gentleman named Dr. Branemark. And he created and he discovered the value of osseointegration, and it eventually led to the modern dental implant. So the dental implant that you see nowadays came from his work back in the 1960s, right? His son, also known as Dr. Branemark, he took his father's research a step further, right? So he decided to implement the use of osseointegration with amputees in helping them use a prosthesis without having to use a socket. Okay. Now, nowadays you're hearing a lot of buzzwords on the internet. You're hearing osseointegration, osseo-anchored, bone-anchored prosthesis. They all mean the same thing. It's when you put the metal implant into the bone, it comes out of the body, and you attach the prosthesis directly to it. Okay. And that's where all of that ends right there, right? So let's talk a little bit. So Dr. Doherty, tell us a little bit about how you became involved with performing osseointegration for your patients.
Yeah. So essentially every orthopedic surgeon these days uses osseointegration, and it's a technique and a technology that, I mean, has revolutionized our field, whether we're doing a fusion in the spine, some sort of foot and ankle procedure, or hip and knee replacements. I use osseointegration and the principles of that every single day. And like you said, I mean, it is the concept of having bone integrate or grow into a metal. And this we refer to as biologic fixation. We use a lot of other methods of fixation. We try to put screws in things. We try to cement things into the body to get immediate fixation. But if you achieve biologic fixation, where the bone literally grows into the metal, it's a very durable, it's long lasting, and it modifies itself over time in response to different stresses within the body. So it's kind of that optimal way to affix a piece of metal to the body. And it's revolutionized orthopedic surgery, and we've gotten really good at it, and we've developed systems that optimize the bony ingrowth and optimize that connection. And I mean, I remember every test I ever took during my training, there's questions about what pore size, how much micromillimeters should it be away, et cetera, but we've gotten really good at it, and we'll talk about it later, but some of the unique aspects of the OPRA system, I mean, they really, really go above and beyond in the science to make osseointegration work. So where it came into my practice, I was probably a third-year resident, you know, just living on coffee, living in the hospital, long nights, early mornings, and we had the opportunity, we had somebody come in and give us a lecture about this novel technique called osseointegration. And it was one of those ones where a lot of the lectures, you're just trying to make it through the day. You're just, okay, blah, 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 another femur nail, et cetera, et cetera. But this one really sparked my interest, and it was incredible. It was something that, it was just science fiction meets reality, and I wanted to learn more. So I emailed the person who gave the lecture, and the next thing I know, I'm signed up to go to Australia for 3 months and do a little mini fellowship, if you will, in osseointegration, learn all about it, see a very high volume surgeon that was performing a lot of osseointegration. And from there, I got to go to Iraq with him, and we spent a couple of weeks in Iraq and kind of the war zone where there were a lot of severe war injuries, a lot of IED explosion type injuries that resulted in limb loss. And so a lot of patients that were in need and were really struggling with the current care that they were receiving. And so I got to do a lot of them there. And it became something that I felt was one of those cutting edge technologies that was going to be transformative. It was going to sort of shift the paradigm in a way and how we treat patients with limb loss and how we can potentially make a better experience, make them more functional, which is kind of why we all go into orthopedic surgery, to make patients more functional. So fast forward a couple of years, I did my fellowship. I kind of, got into the bread and butter of orthopedics, hip and knee replacements, and always had in the back of my mind, I want to bring osseointegration to our practice, to Texas, and it just didn't exist at that point. And this is about 4 years ago. And we had some really motivated rehabilitation doctors and people that were, from the medical aspect and the rehab aspect of everything, excited about the procedure. And they needed a surgeon to be as excited about it as well. Well, at the beginning of practice, you don't have a ton of things to do, so you can focus your efforts on things that are unique and interesting and stuff you wouldn't necessarily get to do if you were just doing hips and knees all day long. So
Sure.
I took that opportunity to kind of really go full into it. We got the program started. FDA approval came right at that same time. So it was kind of a perfect storm of FDA approval, motivated doctors. Everybody got together and we pushed it forward and developed a multidisciplinary clinic, and we really got off running and have never looked back. I mean, we're still growing and still all loving it. So it's
still going. No, that's wonderful. So we've got Drew saying that he was just cleared for OI at Hopkins. Robert says, it's been 5 years amputated, tried numerous prosthetics, was scared to have this procedure done, but seems to be my only hope to truly returning as close to normal as possible. We've got Jerry Ann coming in from Arizona. Tom says, from Australia, and currently my first prosthetic leg so far, 12 months on this leg. Thank you for your awesome advice. No, glad you guys could be here. Let's see, Julie is in Texas, so she's a fellow Texan there. What about below the knee amputees? And we're going to talk a little bit about that as we go along, Julie. And then Rochelle's also asking, can they do that surgery for limb loss for hands? So globally, with the OPRA, and again, I'm speaking on behalf of OPRA, globally, they do have transhumeral. They have transradial, if I'm not mistaken, Dr. Doherty, and they also have for digits. So for the thumb, I believe they're developing that. Are we seeing that yet in the United States?
Yeah, so one of the main reasons and one of the early reasons that Oprah was so attractive to me and our group was the FDA approval. And with FDA approval, it's not just a small little tag that's slapped on the box. That is years of work, years of research, and extra milestones that have to be crossed in order to gain that. And so it's the most researched system out there. It's the most scientifically driven system that's out there. And so for sure, Oprah's gone through a lot and has developed a lot of really unique aspects to optimize its system. With respect to the transhumeral, transradial, and digital systems that exist, Oprah, and I don't know if they call it Oprah for all of those systems, but the Integrum company does have applications for all of those levels of amputation. And the concept is the same. It's a optimized porous titanium tube that has ingrowth potential, and from there it's all about the attachment pieces, and I think they've done a fantastic job developing those systems. Although they're not FDA approved for anything except for a transfemoral amputation at this point, there's certainly many avenues in terms of humanitarian use, experimental use that will allow you to utilize these in other levels of amputation.
Okay. So I just heard back from Integrum, and they said that yes, that all of them can be done through compassionate use. And guys, we're going to talk a little bit more about what that means as we get into the details of OPRA versus the other types. So let's just kind of go over that, right? So I mentioned that osseo-anchored, bone-anchored, and osseointegration, they all mean the same thing in terms of bone fusing with metal, okay? But then you probably have heard terminology such as pressfit and screwfit, and that's where we start to see the differences in osseointegration, okay? So there's 3 primary methods of osseointegration: screwfit, pressfit, and then something called fixation with transverse cross pins. And that one's not one you're going to hear a whole lot about, but I had to put it in there because we are seeing it, okay? And the 4 big methods that we're going to be talking about tonight are OPRA, ILP, OPL, and compress. And we're going to kind of go into more details and keep repeating the information on that. To date, when I was reading all the research papers and everything I was reading, there's been over 17 different kinds of osseointegration put out there. Obviously, not all of them have made it to market. Some of them never even made it to clinical trials. But there's a lot of factions out there trying out their hand in creating different methods of osseointegration, okay? So let's talk about the screwfit. There is only, to my knowledge, one screwfit system out there for osseointegration, and that is the OPRA implant system made by Integrum. So this is the one that I mentioned earlier that was developed by Dr. Branemark. It is the first osseointegration developed for the human body and for amputees. And it was first done in 1990, I believe was the very first surgery done by Dr. Branemark's son on an above the knee female. And that's where we have research dating all the way back to 1990. So with the OPRA system is the one that we have the most research studies and outcome studies to date. And it's funny, whenever you just do a search on PubMed or any of these database systems, the majority of the research you're going to see is on the OPRA implant system because it's been around the longest. It's a 2-part procedure, right? So with part 1, the first surgery, you have the fixture that's implanted into the femur, into the thigh bone, and then everything is closed up. So the skin is closed over it, and the patient is allowed to heal for 3 to 6 months. Is that about right?
Yeah.
Giving time for the bone to fuse in with the fixture, okay? In the part 2 of the surgery, then they create the aperture, and that's basically the hole in the body where the abutment comes out and then it's attached to the prosthesis, okay? And this usually involves the work with an orthopedic surgeon, with a plastic surgeon. They come in and they create this aperture site. And then after that, they do a weight-bearing protocol that can last about 3 to 6 months as well, okay, before the person is up and walking independently. And it's a very meticulous protocol. Right now, a lot of the therapists I know have used the protocols developed by Walter Reed for the Rehab protocol for the OPRA implant system, okay? And the OPRA system is known as a 3-part modular system. So it's got the fixture, the part that goes into the bone, the abutment, the part that comes out of the body, and then the axor 2, and that's the part that connects to the prosthetic device, all right? So tell us a little bit about who is the optimal patient for the OPRA implant.
Yeah, so I think that the optimal patient, you basically the optimal patient for osseointegration is the optimal patient for really any surgery or any surgical procedure. So in my mind, the optimal patient, obviously a transfemoral amputee, and somebody that is relatively healthy. And so a lot of these people fall into the category of potentially somebody that experienced a trauma. Car wreck, motorcycle accident, a work-related injury. They're otherwise healthy and they had a severe event happen in their life that resulted in limb loss. There's also a group of people that are potentially tumor patients or somebody that had cancer that was unable to be managed with limb salvage, and ultimately amputation was their best way to beat their cancer. And that's about, I'd say, half of the patients out there, a high percentage of the patients that undergo limb loss, particularly in the United States, are patients that, am I still there?
Yep, you're here. You're good. You're good.
These are patients that have vascular conditions, diabetes, or peripheral vascular disease, and these fall into the potential risk category for sure. So your ideal patients are patients that have excellent vasculature. They don't have peripheral vascular disease. They don't have comorbidities such as diabetes. They are not morbidly obese or obese. They have good fitness. And these are patients that, it's essentially a no-brainer if they are struggling significantly with their socket, if they're having wound issues, skin breakdown, if they're not confident in their socket, if they're having falls, or if they, they perspire significantly with it. If there's any reason for their socket failing them, a lot of these people end up with these $100,000 legs that become bedroom ornaments. They put them in the corner of the room, they put them in their closet. They don't wear them because the socket bothers them so much. And, I've given a lot of talks and everything. And my favorite slide is always the slide where you've got these ancient Greek or Roman ruins and you find a socket that these people were utilizing for their limb loss, and it makes sense. I mean, you put yourself into a socket, you attach your prosthetic leg to it, you go, and a lot of people do okay with that, but about 75% of people are going to struggle with that. Well, it's 2,000-year-old technology that they're using, and we've gotten a lot better with the materials, and we have amazing people that make these sockets now. But if you gain 5 pounds, if you lose 5 pounds, it might not fit again. It might always just have that one little area that rubs a sore spot. And so eliminating the socket becomes obviously the motivation for people. And frequently they'll get out of their socket, and then you'll suddenly see that they're using their leg a lot more. They're wearing it every day. The time to put it on is significantly less. They're happier with it. They can feel the floor when they're walking. And so, I think we all kind of understand who the ideal patient for osseointegration may be. Somebody who's active and motivated and wants to get back after it. But, one of the things I think moving forward in the future is identifying patients and identifying the patients with comorbidities that would also benefit from the procedure. And that's where it's really helpful to have a big multidisciplinary group where you do employ, prosthetists that are experts, you have rehabilitation experts, you have people that can assess the vasculature of patients and get a little bit better of an idea with actual numbers and data who can potentially heal these wounds, because the biggest thing at the end of the day is the vascular support. Most everybody can probably tolerate the stage 1 surgery and have the implant put in and have their bone grow into it. It's a really nice implant. There's a lot of technology, and it's almost certainly going to work in terms of the bony ingrowth. The big stage is stage 2, and developing what we call a flap of the skin and undermining all of that tissue and rearranging it and bringing it all back down into a way that's going to not only be stable, but it's going to grow and it's going to heal in a way that supports that all of that work that we do underneath there is the big thing. And having excellent vasculature and having the capacity for healing is essential. And so there's, in my opinion, just a small group of people who don't fit that bill, and we test them in all sorts of different ways to make sure that their vasculature can handle that. And frequently a lot of these people that do lose their limb secondary to a vascular complication, they fall into kind of one of two different categories. Either they're going to unfortunately kind of continue some of the things that led them to this pathway, uncontrolled diabetes or severe heart disease and non-compliance with treatment, things like that. But the other group of people, somewhat of a wake-up call. They've lost their limb, they get really serious about their health, they become motivated, They want to, essentially make up for lost time. They've been struggling with a dysvascular limb for often years before the amputation occurs, and they suddenly become, some of the best patients that are just excited. They see it as a second chance. They want to get back into activities. They want to continue the exercise that's going to lead them to better outcomes, not only for their function, but also just their underlying medical comorbidities as well. And so there are a lot of osseointegration surgeons that get a little nervous and scared, and rightfully so, about vascular patients, but I think that that's probably the biggest group of patients that stand to benefit from something like this, and particularly if they're with a group that can help them optimize themselves and lead them to better health outcomes, then everybody's going to do better.
No, and I think definitely you nailed it when you said the team approach has to play a role. Absolutely. And in screening everybody case by case basis. You've answered a lot of the questions that have been rolling in with your answer right there. So as far as Julie Wilson says, want to know 2-step OPRA versus the OPL step 1. And that's definitely something we're going to talk about very shortly, Julie. I know that's a very big hang up for a lot of people when they look at the OPRA system versus the pressfit system. And they say, well, why would I want to go through 2 procedures versus 1 and done? So we're going to talk a little bit about that right now. All right. So we talked about the OPRA, and again, guys, I don't always think of it always as OPRA, OPL. I think of it Screwfit versus pressfit, and that makes it a little bit easier in my brain to understand, right? So let's talk about the pressfit. It started with something called IPL, that stands for Integral Leg Prosthesis. You may have seen those initials hanging around the internet somewhere. It's made by a company called Orthodynamics. And it evolved from a really early stage pressfit device that was made in Germany, right? And so basically the first human trial with the ILP was done on an 18-year-old in 1999. So almost a decade after the first procedure done with OPRA, okay? It is a pressfit method, and this particular pressfit method also requires a 2-stage procedure. A lot of people say, well, all pressfit is done in 1 stage, and that's not necessarily the case. So with the ILP, it is a 2-stage procedure. Phase 1, it's the implant with a temporary plug inserted into the end of the implant and a full wound closure, very similar to the OPRA stage 1. And you have a post-op, you got rehab for about 6 weeks there. And then with phase 2, that's where they form and they create the stoma, okay? And then they progress to weight bearing, and they have their own weight bearing protocol, okay? The ILP, and let me make sure I keep saying the initials correctly because I always get my initials mixed up. The IPL, the IPL was the precursor to the OPL. And that's the one you guys will probably see the most on social media, right? OPL stands for Osseointegrated Prosthetic Limb. And this is made by Promedica Manufacturing, and it was created by Dr. Muderis, which is with whom Dr. Doherty trained in Australia and Iraq. So can you tell us a little bit about the OPL device?
Yeah. So, I even throughout my training and everything, so just to clarify some of the terms and everything. So pressfit, I mean, it sounds, more complicated than it is, but it's literally you take a reamer and you create a hollow cavity, and then you put a slightly larger device inside of that, and you slowly kind of work its way in to fill that void. And so it achieves an initial pressfit stability because it's a large bore cylinder that gets pressed into the bone. That device is not necessarily as stable as you would want it to be right off the bat. And so one of the biggest differences between the two systems is the pressfit systems employ the use of something called a collar. A collar is a widening of the prosthesis or the implant right after it leaves the bone. So as you're putting it in, the collar is wider and it engages the end of the bone. You can't push it in any further because it's got that collar on it. And so with pressing that large diameter device up into the bone, along with the collar, you achieve essentially stability, or the prevention of the device from subsiding or pushing further inside of the bone with all of that. And it's a tried and true method. You know, all of our hip replacements these days utilize this type of a mechanism. A lot of knee replacements with stems utilize this mechanism. And so it's an excellent method of fixation. However, it does have its downside, in my opinion. And I think that when you're comparing the ability of the two systems to have bone grow into it to achieve the name of the surgery, osseointegration, I think both of them are excellent options. I think they both do a fantastic job. I think that they are both excellent in achieving bony ingrowth and achieving that long-term stability that we all want to have happen. However, when you compare the kind of soft tissue aspects of the two procedures, I think that's where the real difference lies. And so the pressfit versus screwfit is a little bit of a red herring in the sense that they both work, they both grow in, they both achieve fixation. However, when you're looking at it from the outside, once it's all said and done, the stoma, or the aperture where the device protrudes from the skin, I think that's where the real differences lie. And what I've really seen over the years of, you know, I still follow tons of patients that do have the OPL system, that have either gone to Australia or had this done somewhere else, and they're living in Houston and they need somebody to follow up with. So they come see us and we talk to them. And one of the common recurring, not necessarily complications, but downsides of the OPL system is some of those stomas, they never really achieve soft tissue integration into the bone because they can't. The bone's capped, it's collared, and the bone does not allow for the soft tissues to ever essentially heal down to the bone and integrate with the bony architecture underneath and achieve stability of the soft tissues. One of the reasons the dental surgeons have had such amazing outcomes with their dental implants is the gums around your tooth, they don't move. They're very stable, well adhered soft tissues. If you look down at your thigh, and if you just grab your thigh and move it, there's a ton of motion in that soft tissue. There's pistoning up and down, there's torsion, it all moves a lot. And so if you've got a large implant that's coming out through an aperture that's moving a lot, that all that skin and all of that fat and muscle underneath wants to do is stabilize and adhere to something. And so it'll try to adhere. And with the larger stomas and with the larger OPL system, you certainly get pistoning, and that movement leads to granulation formation, scar tissue formation, and potentially more drainage and just a larger gaping wound. Yeah, and then compare that to the Oprah system. One of the goals of that surgery is to have the soft tissues actually adhere to the bone as well. So you not only have a stable implant inside of the bone, you also have a stable soft tissue envelope around it. And when that all heals together and it all heals appropriately, the skin, the tissue underneath, it doesn't drain. It forms a very nice mature stoma. And you know, one of the best ways it's been described, I think, in my opinion, is it's like a deer antler. So, you know, a deer's antler, it grows out, it penetrates through the skin, and then that skin just forms a perfect little ring around it. That antler is connected to the skull inside, but there's no communication, there's no drainage, there's no open wound. It's all an integrated system with the soft tissue, the bone, the implant, and it's great. And so I think that that's a huge benefit to the Oprah system, in my opinion.
And Dr. Doherty, I'm going to go ahead and put a picture up that it'll show a side-by-side comparison. And guys, I do have a couple of pictures here. If you're squeamish about seeing some of these pictures, I'm giving you advance notice right now, so you have a few seconds to click off. And I'm going to post a picture. Is that coming through? Let me go ahead and enlarge it. There we go. So guys, as you can see over on the left here, this is an example of the Oprah where it's nice and tight. And you can see it looks like it's almost like a part of the metal. It's adhered to the metal. And then here's an example of the pressfit where it is going to be a bit more open. You're going to see some of this, sometimes some yellow eschar forming right there on the opening site right there. Dr. Doherty, is that picture coming through okay?
Yeah, no, it looks exactly, yeah, what we see all the time.
And then just to give another example, so I grabbed another picture, guys, so we can show you. Sorry, with this I have to like exit, go back in, exit again. So here is a wonderful example of the Oprah system. And what I love about this particular picture is you can see the movement around the attachment right there. So you can see like around the attachment, that skin is adhered and it's really nice and tight around the abutment, but you can still see movement of the thigh muscle around it.
Yeah.
Hopefully that came through.
That's a great example, and
That's a really nice, yeah. And that's how they like all the Oprah systems that I see. That's what they look like. And then I am going to. All right, here's another example of the OPL pressfit. Okay, and you can see what Dr. Doherty was talking about. This pink tissue right here is what's called granulation tissue. So the granulation tissue is there because as a result of the skin kind of rubbing up against that area around that part of the abutment coming out of the OPL right there. So that's what eventually that friction right there is going to cause some of the drainage and that granulation tissue, pink granulation tissue, to be present. Okay. All right, guys, thumbs up. Let me know if you saw that. Let me go jump into the comment section because I know you guys have been posting your comments and questions, and let's just see what you have to say. Julie, I hope that kind of helped answer about the one-step procedure with both. Let's see. Thank you, Ed. I appreciate that. Robert says, I have an 8-inch residual limb and not able to fit a socket well. And guys, I'll be honest, a lot of the folks that come to me saying that they are thinking about osseointegration, it's because they have very short residual limbs as AKs. And suspension is, quite honestly, it's a nightmare, even with the most skilled of prosthetists. And especially if you're someone who's an active amputee and you really want to get moving and get going, and you can't just get a good suspension on that socket. So we see a lot of success there. John says, my surgeon therapist have mentioned that according to the guidelines sheet I was given from Hopkins shows the phase 1 is generally 6 to 7 weeks anyways, depending on how well someone handles the weight. Yes, and this is something I've had a lot of discussions with a lot of my colleagues and saying, okay, we have these beautiful protocols for weight bearing written by Walter Reed. And as we're doing more of these procedures and seeing more patients, we're seeing, okay, patients who perhaps are on the lighter side, maybe less than 120 pounds, their starting weight bearing is going to be much less than someone, for example, who weighs 180 or 200 pounds, and adjusting it accordingly. And it's very similar to the protocols that physical therapists use when someone is coming back from a femur fracture. And we're being told, okay, they can do partial weight bearing. Now they can do weight bearing as tolerated and progressing the patient that way. So there's a lot of similarities, a lot of parallels there from the work that PTs have been doing already for years. And I know, Dr. Doherty, you mentioned that just with your experience with total hip and total knee patients.
Yeah, totally. I think that for sure. I mean, so one of the interesting things in terms of the weight bearing comments and things like that is there's something called Wolff's Law. So Wolff's Law is that the bone is responding. The bone is a living thing. I mean, it doesn't change as rapidly as some things do. Like if you cut your skin and it heals up, it'll remodel relatively quickly. Your bone also is remodeling constantly, so it's turning over. Your bone's eating itself away and then laying down new bone in response to the stresses that it's seeing. And so if you're having somebody that's non-weight bearing, it's a less than optimal scenario for their bone. And so a lot of the people that we see, first of all, if they're in a socket, that bone, depending on the type of socket that they have, is probably not seeing very much stress, and it's probably not remodeling. And so significant osteopenia or low bone mineral density can set in. Likewise, once you do the procedure on one of these patients, in my opinion, I do think that getting them into that weight bearing phase on the shorter end is a good thing. The ingrowth starts immediately. The implant is in there and it is exposed to the natural biomechanical forces that it's going to see, and it's going to start ingrowing. And so in a controlled fashion, yes, particularly in a light patient, exposing that implant to some weight bearing is going to accelerate the process of forming that durable, long-lasting connection. And so absolutely, I think we're all looking for strategies of accelerating the process as much as possible. And I think that's why that, in the initial protocols, it was 6 months between stage 1 and stage 2. And some of the work through Walter Reed, we've kind of cut that in half. And then now you're starting to see a trend towards even shorter times for certain more optimal patients. And so I'm totally with that. And I think that it, also to the patients, it's frustrating to do a lot of this work, go through this process, and then it's like, well, you can't use it yet. You got to wait a little bit longer. And I understand that, and it's frustrating. And I end up telling a lot of people, we didn't really do this for you to be perfect in 3 months. We want you to be awesome in 3 years and 10 years, 15 years, etc. And so, give it some time. And I know you're excited, but I think that the protocols exist for a reason. They're trying to follow a standard process that allows people to have the best possible chance for success. And so, but to their point, yes, I think that certain specific patients can be accelerated, and it's just like anything. I mean, I know the first and last name, and I have the phone number of every patient I've done this on, and so everybody is in a highly customized plan that, if they have a headache one day, they're texting me, and it's like, okay, we're going to work through this, we're going to figure it out. And so it does give you a lot of leeway to say that, you know what, you're a light patient, you're young, you have every possible biologic advantage to yourself. And so, yeah, I think we can shave a few weeks off here or there and get you up and moving more quickly. Part of the 2-stage process, though, that is important is there is a part of the stage 1 procedure where we are implementing bone grafting. And this is another part of the OPRA system that I think is super helpful. But what we do is we basically put that device in approximately a centimeter or 2 centimeters further in from that cut end of the bone. And then we pack behind it with bone graft. And this is bone graft that we either utilize from up inside the femur. Sometimes we harvest some from the pelvis. Occasionally we'll use part of the amputated bone that we just took off to in the bone mill and grind it up, and we'll pack it in there. But what that serves to do is it essentially encapsulates the entire device inside of their bone. And so up on the top, on the sides, it's all encapsulated in bone. And then down at the very end of it, where other systems might put a collar of metal on the end of the bone, the OPRA system utilizes bone graft. And so that device is fully encapsulated inside of the bone. At that point, it basically becomes this real handy, nifty little docking station for things to go into. It becomes a part of the bone, more in a sense than other systems. And so I'm always amazed when I come back for the second stage just how cool that bone graft is, because you can't see the implant anymore. I mean, you can shine a light up in there and you can look and you can see some glimmering little glints of metal.
Yeah.
But for the most part, you're looking at a bone that's been bone grafted, and there's this little perfect little stoma or hole in the bone to put the abutment into. And I think that makes a lot of sense, and it provides that bed for the soft tissues to grow into, and it provides, I think, the optimal kind of setting for all of the soft tissues. And I keep bringing up the soft tissues because, despite the fact that this is called osseointegration, I mean, this is the make or break of this whole procedure is the soft tissue. This is what people that don't like it complain about. This is what people that do like it love about it. It's all about the soft tissues, and so it's essential. And I think that the OPRA system really provides that bed of bone for the soft tissues to grow into. And trust me, I think all day, every day about, like, gosh, how could we make this a single stage procedure? How could we eliminate the second stage? But I think that in terms of the procedure's success, and in terms of having a happy patient for years and years and years that doesn't develop drainage or a painful little granuloma or something like that, The second stage often becomes an essential stage that allows it to work better than it would otherwise.
Absolutely. And I'm so excited that you said everything that you said, because this is exactly what I try to let people know about is, yes, it does take longer with 2 stages. Yes, there is more time involved in the recovery process. But when you look at the long-term goals and the outcomes there, and guys, by the way, we are doing a show just based on statistics and outcomes in September. And that's going to be another huge show. So we're going to be talking a lot about that at that point. From a physical therapy standpoint, and I was having this conversation with Kurt Collier. He's probably the prosthetist that I think knows the most about osseointegration, period. But he and I were having this discussion, and he brought up a very good point. And as a physical therapist, I'm like, well, duh, I should have thought of that myself. You know, when someone is in this horrific trauma accident, right? And I spent my first years working in a level 1 trauma ICU center in Miami, right? Multiple fractures, serious fractures that require pinning and metal rods and everything put into the body. As physical therapists, we don't just pop these people on their feet and expect them to start walking. It takes time to heal, and we cannot speed up the body's healing process, right? There's just no doing it. It's basically time that is needed for that bone to remodel. You know, and so you can shave off a little bit of time here and there for someone who's healthier, somebody who's perhaps getting that bone turnover a little bit faster. But ultimately, you need to give the body time to heal and to fully integrate. And as Dr. Doherty beautifully stated, it's not just the bone, it's soft tissues, right? You guys have heard me talking my ear off on this show about how it sometimes takes up to 2 years for some of these soft tissue remodeling to take place and for that residual limb to get that final shape for the socket. So for a procedure as extensive as osseointegration, how are we not going to give the body that same amount of time to heal properly? And then the complications that happen when you don't. And I would see many times, especially in the trauma center, when you have especially the young bucks, right? They're trying to get back to running, or they're trying to get back to these sports after these very big traumatic accidents. And they end up causing further complications down the line because they were pushing their bone too hard. So to me, it just kind of is just common sense, that the body has a timeline, and we have to respect that timeline.
In trauma, the big saying everybody will use all the time is anytime we fix a bone, basically there is a race that goes on between fracture healing or fracture union and implant failure. Because if you've got these extreme stresses, like the muscles are pulling, you're putting your body weight on it and everything, that bone, it wants to displace again, it wants to fail, but it's being held in place by this implant. And the implant's only as strong as, you know, you think it would be way stronger, but it's like the paperclip. You bend it slightly enough times, it's going to break at some point.
Right. Yep.
Okay. But it really is amazing to watch the body heal, and giving it the time to do that pays dividends. And like I said, I mean, we don't do these on these patients for them to, you know, oh, I've got a wedding to go to in 3 months. It's like, no, I've got grandkids that I want to be with for the next 10, 15 years and watch them grow up and be able to walk around the lake with them and do all these amazing things. But it's an investment. You gotta give it the time to heal.
It is. So let's just briefly talk about, because I mentioned that there were 3 types. We had the Screwfit, the pressfit, and now let's talk about a little bit about the compress. Not a lot of folks, you're not going to hear that a lot. I know I've only heard it in the research talks. It's made by Zimmer Biomet, and it was originally designed for limb salvage patients, specifically those with bone tumors. And right now, so it's basically, it's the rod going in with the cross pins to anchor it in. So it feels like a lot of the procedures I would see on the orthotrauma patients.
Yeah, so the compress system is super interesting. I mean, it's an incredibly novel design, and those cross pins are a little different than the typical cross pin where we're using either a jig or an imaging device to put a screw that goes from the outside of the bone through the device and then through the other side. These cross pins are contained within the device, and they're through a mechanism. And so basically, you will put that device in there and you'll activate the cross pins that then expand out from the implant and embed themselves on the interior of the bone. And so this system is basically it also achieves ingrowth and osseointegration, but it's such a short segment of fixation that essentially you don't necessarily trust it to not wiggle, and you don't trust the ingrowth to occur. One of the things that's required for very, very good bony ingrowth is an implant that's not moving at all, even micro motion.
Okay.
So less than micromillimeters of motion are essential for the bone to ingrow into this. Or if it is wiggling, that process won't happen and you won't end up with osseointegration. So
Okay.
those little cross pins stabilize it for a period of time as the bone ingrows. And like you said, it was developed for tumor patients who frequently will have a very, very significant portion of their bone removed, and you're not left with a lot to work with, and you don't want to, I guess, burn bridges in the future by, taking more bone or reaming away more bone. So we try and get away with these short segment fixations where you put it in, you have the ingrowth occur, and once the ingrowth occurs, it's good. It's enough ingrowth if it occurs to support the system, but those little cross pins are utilized to stabilize it initially. And I think that, this system, in terms of the osseointegration realm for amputees, probably the least commonly used system these days. I think there was a period of time where it was more commonly used just because it was a available product on the market that hospitals could achieve and acquire, and it was already in the hospitals, approved for use implant categories. And
Okay.
so you utilize this off-label for osseointegration and
Right.
on the back end. Fortunately, now we're in this era where we do have systems like the Oprah system that is fully FDA approved for this indication, and there's other systems available that are also developed for this actual indication, and so it's a little more fine-tuned. It's being used as it's intended to be used, as opposed to, okay, how can I retrofit this device that's typically used for something else into a different use category. So, I really don't have much experience at all with the compress system, but it's certainly it's one of the more novel designs of orthopedic implants that are out there, which is cool.
That is cool. All right, guys, I'm going to start answering. We're going to start reading some of your questions. But before I do want to post the second giveaway. I'm having a lot of fun with these QR codes. This is going to be my new toy with the streaming service here. So you see a beautiful picture of my friend Susan. Susan is a bilateral above the knee amputee. She is received the Oprah system for both of her residual limbs and has an amazing story. She's been on my show before. If you want to hear her story, go to my YouTube channel, Cosi Talks. And yes, that was a shameless plug for my YouTube channel. And you can hear the interview that I did with her and also with her therapist, Ed Lyons. So guys, I am always about getting as much information, being as informed a consumer as you can be, because that's exactly what you are. You are a consumer for your health, right? Whether it's for the newest prosthetic technology or new procedures. And part of that involves getting information from credible sources, such as Dr. Doherty here, but it also involves talking to fellow amputees about their personal experiences. What I like to recommend, the reason why I like to recommend folks to specifically seek out Integrum ambassadors is because they have received training. So it's not just about their own personal story and journey, but they've received training. They can answer a lot of your questions and give you the right answers. And that for me is so important. We do have a lot of misinformation out there on the internet with Dr. Google. So whenever I can point you all in the right direction to somebody who can give you good, credible information. So scan the QR code and you can have the chance to talk to an ambassador such as Susan, who's been there, done that. And another thing I do want to add to this, guys, a lot of people will say, well, they're ambassadors. They had no problems, no complications, and everything went swimmingly for them. And that's why they like Integrum and Oprah. That's not the case. Many of the folks who have been ambassadors, they have complicated stories as amputees. I don't think I've ever met an amputee who hasn't had a complicated story. And Susan had, she has an incredible story right there. So she can tell you about the good, the bad, the ugly of osseointegration, and she's very honest and upfront about everything there. So I'm going to leave that QR code up there for a little bit. Let's get back to some of these questions. Let's see. Daniel is asking, is this becoming a procedure for below the knee amputees?
Yeah. So I get a lot of requests, and we do see some below-knee amputee patients in clinic, not infrequently, but so far I've only performed this procedure in above-knee amputees. And to answer some of the other questions out there, we've done 32 OI patients now. A couple of those are bilateral, so it might be like 28 patients with 33 procedures. And so, we're still actively recruiting all sorts of patients. One of the things, though, that's nice about our clinic is, I don't ever want anybody to, oh, well, I'm a below knee amputee, I can't go see them, or they only do above knee amputees. That's not necessarily true. I think that the vast majority of below knee amputees, I think, can achieve a functional gait and achieve a level of satisfaction with sockets that is frequently not able to be achieved in above knee amputees. There's a lot of differences in not only the soft tissue envelope, but also the requirements and the demands that are placed on some of the on not only the prosthetic limb but also the socket. And so one of the nice things is, anybody that does have a below knee amputation, we will see them in our clinic and we'll encourage them to come in, because you're not only necessarily talking to me. I'm one of 3 doctors in that clinic that see patients. The other ones are going to be rehab specialists. There's 2 veteran prosthetists that, I'm constantly just like, hey, that question's for this guy here. He knows everything, and they're all, they get geared up and they're like, oh yeah, well, I can definitely help this patient this way or that way. And so, I love seeing these below knee amputees, because at some point there will be somebody that has tried everything and they've gone to high quality rehab doctors, high quality prosthetists, and they're still struggling. And it becomes one of those conversations most of the time with below knee amputees that I really, really will aggressively maximize all of the non-operative treatments on them. They have to really have a unique issue or have just some reason why a socket is just not going to be a viable option for them. And at that point, yeah, we'll have a discussion with them about osseointegration in the tibia. And it is, a hard enough procedure to get just right and to have an excellent outcome with a transfemoral patient. There are other even more unique challenges, longer lever arms on the implant itself. And then not only that, but the area of bone that you're implanting the device into is less than optimal in the proximal or the top part of the tibia bone, because it's starting to flare out. And so it's, all bones essentially have this, flare in and flare out kind of structure to them. And in transfemoral amputees, a lot of the time you're dealing with that part of the bone that's almost like that center of the hourglass, and you're able to get excellent bony contact. You've got basically a contoured bone that is in the proper location, so that implant is pressing up into that concave portion of the bone, and so it's not going to go anywhere. Whereas on the tibia,
here,
it's
you guys can see it
out and away, and so to put that in there, you're putting it into what we call the spongy bone, which is metaphyseal bone, and it's not the hard cortical bone that we want to implant into. It's a different scenario. It's like the kind of wet sand of the bony world. And so it is not only a higher stress environment on the implant, it's also a less optimal bony environment as well. And so what we've seen in the tibial osseointegration patients, or the below knee amputation osseointegration patients, is they have higher rates of infection, they have higher rates of loosening. And they also have lower vascular support down there too. So it's sort of one of those things where we want to do procedures that are going to work for patients, and it is enough concern for me that there is going to be a complication or a significant complication that there has to be just no other way. It's either osseointegration or they're not walking, and they have to understand that this is not. I can give a lot of transfemoral patients really high levels of optimism, and this is going to work, and we're going to do a great job, and little things might pop up, but we're going to work through them. Whereas in a transtibial patient or a below knee amputation patient, that discussion is more, this is a 50% chance of high level complication, or having to remove your implant, or heaven forbid have a higher level of amputation afterwards because it just destroys your bone or becomes such a significant infection. And so it's not quite as simple of an answer as yes or no. I think that every patient should be evaluated, and we can frequently, with our team of experts that we have assembled for everybody, we can get that patient taken care of and probably have a better outcome doing something other than surgery than what they're currently experiencing. And if they are that unique patient that has done everything and they are still struggling, then absolutely it's something to discuss with them and have that kind of really personal discussion and develop a plan that works for them. So it's not ever a no for them, but it is something that is not quite as well researched or successful as a transfemoral amputee.
Thank you for saying that. I feel like in the past month, I don't know what's in the water, but I feel like I've been seeing a lot of that in discussion on social media lately. And it's a catch-22, right? One of the big reasons for doing osseointegration is for folks with very short residual limbs because they are difficult to get a good suspension on the socket. But in the case of the tibia, right, the shorter that limb, the more that spongy bone, which means you're not going to get a good fixation and a good anchoring. And then if you have somebody who has a long tibia, then they're going to be an excellent candidate for traditional socket use. And you don't want to necessarily put them through that because they're going to have a more active lifestyle as using a traditional socket. So thank you for saying this, because I see so many people saying, well, I see the pressfit or I see this in the BKs and this and that. And I go, yeah, but you really got to kind of ask these questions, guys. And as far as questions that you all should be asking prospective surgeons, Dr. Doherty has checked off pretty much all of these boxes. And I love the fact that he said how many procedures he's done. I believe it was Julie earlier who said, how many procedures have you done? And guys, that is a perfectly legitimate question to ask your surgeon. They should be perfectly upfront and honest with you with how many surgeries that they've done with this. It's not going to be a huge number, guys. And to me, like 30, you said 32?
Yeah, 32. Yeah.
That's quite a big
on
number.
my own. That's in addition to probably like, I don't know, anywhere from 20 to 30 more that I did when I was in training. And so, I've seen a lot with osseointegration, and I've seen, some complications, some of them that have arisen from some outside places that have come to follow me. I've certainly had complications of my own. I think that the biggest thing that, you could ever learn or bring to this job is that, complications happen.
Yep.
One of my mentors says that, if you're a surgeon without complications, you're either a liar or you're not operating. So, that'll happen. And the biggest thing you can do for complications is, really address them head on and not assume that they're going to go away. You can't bury your head in the sand. And I think that, anybody who really knows me or has been through my clinic understands that about us. And, working in it, this isn't a place this isn't a procedure or a specialty where you can do it in a, small little private practice environment, just, funneling people through the door. I mean, we have really developed a robust system where, we have, one of the top couple rehab facilities available to us that is dealing with amputees, osseointegrated amputees, socket-wearing amputees. They're dealing with spinal cord injuries. They have every resource imaginable available to them. We have plastic surgeons that we utilize all the time. We have prosthetists. And these are all people that are in clinic with us. And so when you come to see us in clinic, I'm not going to tell you like, okay, I think you're a good candidate. Now just go see all these other people and we'll touch base again. It's all right there. You'll talk to all of us and you'll get answers to pretty much every question you have on the spot. And I think it's the ideal way of doing it. I think that it's really the only way of doing it at this point, because there's so many little pitfalls that can happen that have to be optimized before you do anything. And having 3-4 sets of eyes on every single patient really makes it a smooth process.
And I do want to bring that up. And guys, just to clarify, currently in the United States, the Oprah implant system is the only FDA approved osseointegration system, and it's only for above the knee amputees in the United States. Those of you that are seeing the pressfit method being done in the United States, it's being done either through humanitarian, I always mess up this name. Can you help me out, Dr. Doherty? Compassionate use, thank you. Or experimental use. And what I've noticed, and again, I've seen there's one particular surgeon that I know and respect, and he's doing a phenomenal job using pressfit. But there are other organizations that are doing pressfit, and they're not necessarily providing the follow-up needed. And that's something that I've really been hammering on this show, is regardless of whether you go with the Screwfit or the pressfit, OPRA versus OPL, you have to have that team in place, and you have to have a surgeon like Dr. Doherty who is going to have you under a microscope and following you every step of the way, especially those of you who are traveling to these centers and eventually coming back home. What is going to be your safety net when you come home? How is that team going to follow you from a distance? And they're doing it, and they're doing it very successfully. I know there's several places in the United States that are doing this successfully, but there are those that are not doing it successfully. So ask these questions for sure.
Yeah, one thing I've really liked a lot about kind of the current system is, so utilizing Oprah, I mean, they do have a ground game in place. They have people that are not only assisting me in terms of having company representatives there, making sure we have all of the implants and instruments that are required. They're also identifying patients of mine that we have signed up for surgery, and they're like, okay, well, this person's from Arkansas, and so what they'll do is they'll find a good prosthetist in Arkansas, and they'll find a good physical therapy outfit in Arkansas, and they will provide them training. So when that patient has completed the surgeries and they're ready for rehab, it's all already in place. There's not this whole like, oh yeah, y'all aren't here, we're gonna have to find you something. And that's already been done. And what we're finding is there's tons of prosthetists, there's tons of physical therapists out there that are super excited about working with these patients. They just don't necessarily have the resources, and they're trying to put stuff together from the internet or from medical publications. But we not only have our own rehab protocol that we've developed that we can give to them, we also have people that, our physical therapist will jump on the phone with any therapist out there. We'll call them, we'll walk them through the process, we'll explain to them what to look out for. Hey, don't worry about this, it happens with everybody, they'll get through it after a week, blah, blah, blah. Things like that are reassuring to not only the patient, but also to the people that are providing care for him, because we all want to do a good job. We all want to help people and help them get over these recoveries that can be onerous. And so providing that reassurance that yes, this prosthetist that you're seeing knows the system, and if they have a question, they're a phone call away from anybody that can answer those questions for them. It's a really nice network that it makes you less out on a limb with a patient, that when something happens or something needs to be, some troubleshooting needs to occur, there is not just me, not just my team, but there's a network out there that's getting bigger with each patient we do.
Absolutely. So Richard, I'm getting to your question now. He says, love the talk. However, 75-year-old veteran, right, BK, living in rural America with diabetes and vascular issues, I feel on the outside looking in. And Richard, for me, it's not, not everyone is an osseointegration candidate. In fact, I would say the majority, a lot of amputees are not necessarily candidates. I think that the way osseointegration is moving is that it will soon become a normal tool in a surgeon's bag when they are treating and they have an amputee on their OR table saying, okay, what is going to be the best procedure and strategy for this patient? OI is going to be one of those strategies, and it's going to be a normalized strategy that we're going to start seeing. Is it meant for everyone? No. Do I still encourage you to learn about it? Yes, because you're an amputee and this relates to you. And not to mention that you may run into a fellow amputee who is considering it and needs to find a place where they can get the credible information, right? All right, let's look at these. Harsh, I haven't said hello to you yet this evening. How are you doing? Rochelle says, hi, doctor. I'm missing all of my limbs. I'm below the knee on both legs. Could it work for me? No vascular, no diabetes, and I'm very interested in this procedure. So Rochelle, I'm going to go ahead and post the QR code while Dr. Doherty answers about where you can find a surgeon in your area that does the Oprah system.
Yeah, absolutely. I think that I think the most indicated patients for osseointegration are going to be bilateral amputees. You know, particularly patients that have, you know, limb loss, upper extremity, lower extremity, are basically at a loss when it's time to put on a socket and you have to roll on, you know, your sleeve and your liner and all of these things. Even some of the most functional, you know, transhumeral or transradial amputees struggle with the fine tuning of putting on a socket in the appropriate way. And you know, we do have a patient that we performed bilateral transfemoral amputee or transfemoral osseointegration on, and he's also on he's transradial amputee on his bilateral arms as well. And he couldn't really put his sockets on, and so he was just kind of wheelchair bound. And he is now walking. He's, you know, going back and forth to his home country. He's building things. He's taking care of his family. It's one of my more rewarding patients. But even if you're not missing your arms, bilateral sockets are challenging, and the amount of abnormal forces that are exposed, the hips are exposed to, with the deformities that occur in terms of the legs opening up and turning out, and not to mention, you know, this is, you know, one of the unfortunate aspects of having two sockets as a male patient. There's something that hangs down there between those two sockets and can get pinched frequently as you're walking, and it happens once, and that's one times too many. And so it's one of those things where sockets and bilateral amputees are just a very, very challenging scenario to deal with. And so I think that bilaterals are some of our happiest patients. We've done several of them now, and they've done great. And it's a really fun patient population to work with. And another shout out to our rehab team, because, you know, in a traditional single-sided osseointegration patient, you've got a good leg to stand on as you're doing your progressive weight bearing rehab protocol. And so, you know, okay, I can only put 20 kilos onto my right leg right now. Well, my left leg can support me and I can do that. Well, if you have both legs at the same time, you know, how are you going to do that? And so we developed a lot of really kind of interesting and unique kind of tricks for the rehabilitation of bilateral amputees, utilization of Hoyer lifts and other really cool aspects of that have been awesome and have let our patients do great with their bilateral amputations. And so, to answer your question in a long roundabout way, yes, I think you're probably an excellent candidate, and you know, I think you'd be excited to come talk to us, and we'd be excited to see you.
Absolutely. And guys, I'm going to put before I forget, I'm going to put my email address up here. There's so many questions tonight. If there's any questions that we did not get to, please don't be shy. Email me. And if you have questions for Dr. Doherty, if you want to get in touch with him for a possible consult at his clinic, email me and we will make all of that happen. I know somebody said that they would like to speak to Dr. Doherty off screen, off the show. So I believe it was Julie. Go ahead. Please feel free to email me and we can help set things up. So a couple of questions I'm going to pick up here. Let's see. Where was I? Lots of good questions coming in. Good heavens, lots of good questions. Wow. Can you talk a little bit about the risk of infection? That's always a very popular question. And guys, we will be discussing infection rates in great detail in the September show, but I'll let Dr. Doherty give a stab at that right now.
Yeah, I think that the infection thing is interesting. I think if you get it all right, everything integrates and then the skin heals up quickly, I'm like not concerned at all about an infection. I think that you're going to do great and you're just off to the races. There are some patients where you get a little bit of a sag in the stoma, or there's still a little bit of drainage. Those are patients that do have risk of developing an infection. And I think that in terms of the infections that we've encountered, we've not had an infection yet, knock on wood, obviously, that has required any kind of removal of implant. We haven't really even had any infections that have required even a return trip to the operating room. The infections that we've dealt with have been superficial, and part of it is the fact that there is the stoma present. And the body's pretty amazing. We get into trouble with infections inside of the body when they're fully enclosed and encapsulated, and they don't really have the way to get out. It's like the pimple that forms on your face. That's basically a little infected hair follicle or sebaceous gland that it worked its way out, and then once it pops, it just kind of goes away. Your body handles it and it deals with it. It's that decompression that needs to happen, and so the stoma actually does serve as a very important exhaust vent, if you will, to allow some of these superficial infections to not turn into a big, bad, deep infection that invades the bone or invades the muscle compartments and becomes an abscess that may require surgical decompression. And so the infections that we've encountered have been vast majority dealt with oral antibiotics. The patients go on a short course of oral antibiotics, and then in the process of, a week or so, they'll say, oh, my stoma drainage is stopped, it's gone, the redness is gone. And sometimes, I think that some patients do develop some mild infections that are a little unrecognized or under-recognized, particularly in this group. I mean, if somebody has been doing great and then suddenly like, oh, I'm having a lot of phantom pain, or I'm having a lot of, just increased inflammation or something like that, that may be an infection. And so I'm pretty quick to treat patients with oral antibiotics when they do have one of these little episodes occur, because obviously, I think in terms of weighing the risk and benefit of overprescribing of antibiotics versus their place to treat infection, I'm pretty quick to prescribe them to treat these. And fortunately, we've been blessed to not have any patients that have had to go back to the operating room for major kind of infection surgeries and things like that. But I will say that I think my practice is pretty on par with the literature that, up to 30-50% of the patients do experience some form of a superficial infection at some point in that process. And the word infection and orthopedics is really scary, because everybody or most people have heard of these horror stories. A lot of my patients have lost their limb because of a severe infection that was unable to be controlled. And so it's a scary word that comes up, but fortunately, when we're dealing with this patient population, the vast majority of the patients that do experience an infection are very, very easily treated with a conservative, just oral antibiotic that resolves it.
And again, guys, we'll go into those statistics. Not only do we have the statistics of the superficial infection, meaning they just need a short course of antibiotic that is done at home, versus those that need much smaller percentage that need IV antibiotic, and then in extreme, then also very small percentage of cases that require either an explantation or surgery to go back in. That being said, that's another difference between the OPRA system and the pressfit, and you can hopefully expand on this a little bit, Dr. Doherty. There's almost a fail-safe mechanism built into the OPRA system, so that if it has to be removed, there is preservation of the residual limb length.
I mean,
the way that the implant is done, there's a difference
so
there.
I would say, I mean, potentially. I mean, anything's on the table when you're dealing with a severe infection that's requiring, implant removal or something like that. I will say, one of the other positive aspects of the OPRA system is the implant itself is 8 centimeters long, so it's just about, 2 inches, a little over 2 inches long, or 3 inches, I guess I should say. But it is about half the length of the OPL system. And so when you're dealing with particularly some of these really short amputees, the OPL system may have to be significantly customized to fit a patient like that. And so when you're dealing with some of the really short segment amputees, it's nice to have a system that does not take any more bone than is necessary. And you can actually preserve more bone in the sense that you haven't implanted into it, you haven't essentially burned that bridge with a implant that's significantly longer and is taking up more of the medullary space of the femur.
Okay, there you go. Pam is asking, what about osteoporosis in women? Can this be an issue?
Yeah, of course. I think that particularly in women, particularly Caucasian women, the highest percentage of patients who suffer from osteoporosis are going to be, white females. And so, for sure, if you're dealing with the added comorbidity of having an amputation in that limb, that bone is going to be even less. Is going to have even less capacity to maintain normal mineralization. So, yes, it is certainly a problem, and it's one of those things where I've not encountered a patient that is so significantly osteopenic or osteoporotic that they could not tolerate the procedure. But you start to really every single patient we see, the X-rays comparing the normal or unaffected limb to the amputated limb. Anybody that has any knowledge of X-rays, you can look at it and just see, wow, there's a lot less calcium in that bone than there is on the other side. And so it certainly becomes an issue, and particularly the higher up you get in the femur, it becomes more of an issue, just because you're starting, just like we were talking about with the top of the tibia bone, you start getting into a similar scenario up at the top of the femur bone as well. And a patient that already has significant osteopenia on top of an amputation, those are ones that you get worried about in terms of, even if you can get the bone to grow into the implant, which is very doable in everybody essentially, it's the stresses that it's going to see after the fact, and whether or not that bone can tolerate that amount of stress, and if it can maintain the prosthesis for a long term.
Okay. Jay says, I have a lot of soft tissue. Could that be causing me not to have control of my prosthetic? Yes, that could be one of the reasons, especially if you're an above the knee amputee. I had one prosthetist kind of say it really interestingly, like, trying to create a socket that stabilizes thigh tissue is like trying to put a popsicle stick into a Jello mold and trying to get that to stay put. So you're trying to stabilize that femur into adduction where it kind of pulls in just a little bit. And that's probably one of the bigger challenges of making a conventional socket for an above the knee amputee. So certainly, when it comes to soft tissue, if you've been through the gauntlet of working with different prosthetists and trying different techniques, I've had some folks who decide to go back to the surgeon to either have a revision where they might have some of the soft tissue removed or revised to make it just a little bit tighter. Some folks do end up going to an osseointegration consultation just to see if that's a viable option for them. So Dr. Doherty, do you want to comment on that one?
Yeah, for sure. I think that soft tissue considerations are one of the biggest categories of people that are unhappy with their sockets, and it makes a lot of sense. It's one of those scenarios where, everybody that's listening right now, you can grab your thigh and you just feel it, and you can't even really find a spot in your mid thigh that you can really feel your bone in there. And so when you're thinking about putting all of that into a socket, granted, we're not necessarily bearing weight through the bone in that socket. It's probably, it's supporting you off of parts of your pelvis or off of parts
soft
of the
tissues.
bone way higher
Yep,
up,
and all the soft tissue.
Soft tissues and things like that. So, But when you look at the weight bearing x-rays of these patients, particularly if they have a unaffected limb on the other side, and you look at the alignment of that leg compared to the other side, everybody has adopted there's a characteristic deformity that occurs. It's called abduction, so moving the bone away from the body. It's externally rotated and it's flexed a little bit. And so when you're considering that scenario, not only is that bone just kind of floating out in space and it's pushing out to the side, so that is changing the way the hip socket gets loaded. That is changing the way you move your leg as you're walking and you're using your muscles. You adopt a different gait just to propel your leg forward, and that has ramifications to all of the muscles that are attached. Like your abductor muscles are super important every single step you take, and these are your butt muscles. And if they're basically shortened up and they're not seeing that appropriate load, they're going to atrophy away. And so that's one of the other things, as we bring a patient's alignment back to normal, as we start loading them, as they start walking, their abductors are just like pathetic. They're so weak because they haven't been used in so long. And so they'll have a little bit of a limp at first. And I mean, years and years and years of non-use. And then suddenly it's like, well, I did the rehab for a month and I should be good now. Well, the reality is it's probably going to be a year or two before those muscles have rehabilitated themselves enough and have started firing in a more normal way. And so, it's amazing how much the body atrophies secondary to the non-use of having this just totally abnormal moment arm and angle of your hip joint and everything. And so, that's one of the other things I should mention is, part of, as we've started to grow our program and everything, we've really started to get into some of the research and some of the studies that look at a lot of these things. And so one of the things that the University of Texas has where I work is we have a gait motion lab, and we have the ability to preoperatively look at the way this hip joint is being loaded with things like biplanar x-ray and fluoroscopy as you're walking on a treadmill. And then how does that shift and change after we've done osseointegration? And so we have a few open studies right now that we're enrolling our patients into that are going to hopefully come up with some important answers about just how detrimental it is to walk with these abnormal alignments and how much you can potentially improve as we realign the body into its more natural state.
And now he's really talking my language right there. And I'd love to see one done, like EMG studies on those muscles. Because guys, when I see someone with osseointegration who's done the proper rehab protocol, right, through Oprah, and I just see how they're activating everything. They're activating the glutes. They're activating whatever residual hamstrings that they have left. And I'm just gonna give you guys a quick visual because Bob here wants a piece of the action. So what Dr. Doherty is talking about is, and Bob's not really aligned very well, but in the normal human body, your femur goes in just a little bit like this, right? And part of what's making it go in is the weight of the rest of your leg. So when you have an amputation above the knee, instead of being pulled in, it's being pulled out. And that's the struggle your prosthetist has in putting a traditional socket. They're trying to get this socket and squeeze those soft tissues to get you to put that femur in. And that's why a lot of you with above the knee sockets are complaining about pain on the outside part of your socket because the femur keeps bonking up against there and you feel like it's bell clapping in there. So when you have osseointegration, I mean, you're going straight to the source, you're getting that bone and it's getting aligned properly. So that means that the residual muscles here are being put back into the plane that they were meant to be in to function. So yeah, total nerd flag moment there for me. Cannot wait to see those studies. Guys, we have two winners tonight. We have Brian Waterman, and we also have Jerry Ann for the winners for our two $25 gift card certificates. Please email me. I can try to trace you down and track you down over the internet and social media, but it makes my life so much easier when you can just email me your information and we can mail you your gift card. Guys, this episode is going to be uploaded to my podcast channel as of Friday morning. If you have not seen my listen to my podcast, my team has put me pretty much on every podcast platform out there you can possibly imagine. You can find the information on that on my website, cositalks.com. Once again, I'm going to put my email. Guys, if I did not answer your questions, if Dr. Doherty did not answer your questions, if you want to go see Dr. Doherty, please email me and we will make these connections happen. So first and foremost, I want to thank you so much. I have learned so much this evening, and you have hit so many of the key points of all the confusion I see out there on osseointegration and the differences between the different types. So thank you so much for providing clarity on a lot of these topics tonight and for your time, Dr. Doherty.
Hey, of course, and thank you so much for having me. I just want to give a quick shout out. I see in the questions maybe somebody from Richmond, Virginia. Yes, I went to University of Richmond undergrad, so great.
Oh,
spot.
is that right? We have a
Yeah.
lot of people here from Richmond listening in.
Good years of my life spent there for sure. But no, thank you so much, Cozy. This has really been fun. I mean, it's something near and dear to my heart, and I have tons of happy patients, and you know, our team and everybody that's working hard on this is excited about it, and you know, just really excited for the future. And I'm glad that people like yourself are highlighting it for everybody.
Well, thank you. And guys, a very big special thank you to Integrum. They've been my sponsor now. I've been working with them for the past few years. And I really want to give them a special thank you for this particular show. It's something I wanted to do, and they were fully supportive of bringing the information on all the different types of osseointegration out there. So guys, get out there, do your research the right way, ask the right questions. And in the meantime, guys, thank you for letting us be a part of your lives this evening. We will see you next week, same bat time, same bat